Welcome to CPI 101 Module 2, Quality Improvement. My name is Sumanth Ranji. I am an Associate Professor of Medicine and the Co-Director of Training in CPI for UCSF Health. Our goal for this module is to teach you the basic principles of quality improvement, how to ensure that all of our patients receive the optimal care possible. Our specific goals are to understand the definition of quality improvement, to learn the 6 key steps of QI using an example project from UCSF Medical Center, to avoid the common pitfalls involved in designing a quality improvement project, and to appreciate your role in improving the quality of care for your patients. According to the Institute of Medicine, high-quality care should be safe, effective, patient-centered, and personalized to an individual patient's goals. It should be timely, it should be efficient with no waste of resources, and it should be equitable so that every patient can expect to receive the same high standard of care. Think about the patients that you see in your work area. Do you feel like all of your patients receive care according to these standards? If you're not part of clinical staff, think about your own experiences with the healthcare system or those of your families. In what way did patient care not meet these standards, and what can be done about it? That forms the crux of quality improvement. Many discoveries, including many led by people at UCSF Health, have rapidly improved our understanding of why our patients become unhealthy and what we can do about it. Unfortunately, our patient care systems have not always kept pace. This is what is referred to as an implementation gap. We may know how to diagnose our patients and we may know how to treat them, but unfortunately, all of our patients do not benefit from our latest scientific advances. The process of quality improvement is designed simply to close this implementation gap so that every one of our patients receives optimal care every time. In the previous module, Module 1, we discussed the principles of the lean operating system, using concepts such as Kaizen and going to Gemba and plan, do, study, act cycles to identify problems, eliminate waste, and develop new ways of working. In this module, we'll break down this process a little bit and go through a step-by-step approach to identifying a quality problem, addressing it, and implementing interventions that result in lasting behavior change so that we optimize our way of working and therefore optimize the care that our patients receive. Here are the 6 key steps of a QI project. First, understanding the problem and identifying the areas for change, deciding on a way to measure progress, stating explicit goals, creating effective and reliable improvements, and finally, building upon successes and sustaining the change. We'll use an example project from UCSF Medical Center to illustrate these 6 key steps so that you can understand how we at UCSF have successfully addressed a QI problem. In 2010 at UCSF Medical Center, our hand hygiene rates on inpatient units were well below our goal of 90%. As a result of that, our rates of several healthcare-associated infections were well above national benchmarks, and we were exposing our patients to unnecessary patient safety risks. This clearly became an organizational priority to address, and in the following slides, we'll use the example of hand hygiene as a way to illustrate how a complicated QI problem can be broken down and addressed in a stepwise fashion. The first step of a QI project is to take the time to understand the problem. In Module 1, we introduced the concept of going to Gemba, which means going and seeing the real place. This refers to directly observing the work environment and seeing how frontline providers go about their work on a day-to-day basis. By directly observing actions as simple as how long it takes to walk around the ward to find supplies, you can often identify important things about why a safety problem exists that may not have been understandable otherwise. This first step is also the first common pitfall that many encounter when trying to plan a QI project. Failure to take the time to adequately understand the reason the problem exists in the first place means that it will be very difficult to design the right intervention in order to change behavior. After observing the workplace, the next step is to construct a process map. A process map is simply a visual representation of all the steps it takes to perform a given process. From the clinician's perspective, as you can see, there can be up to 6 separate steps involved in performing hand hygiene before and after seeing a patient. If any of these steps are not performed properly, patients may be vulnerable to contracting a healthcare-associated infection. But it's also important to realize that the clinician's perspective is only one perspective that's important when constructing a process map. If we look at everybody who's involved, in ensuring appropriate hand hygiene, we see that supply chain management, environmental services play a role that is equally as important as the clinician in ensuring that we are protecting our patients from healthcare-associated infections. By ensuring that gowns and gloves are available at the point of care, we can eliminate wasted steps, simplify the process, and make it easier for the process to flow most naturally. Once you have gone to Gemba, taken the time to understand the problem and performed a process map, you will have also identified the areas that need to change in order to make sure that the process is performed properly. The next step is to decide on a measurement strategy for your process. There are 3 different lenses through which quality can be measured, and correspondingly there are 3 different types of metrics that are often used in quality improvement projects. None of these measures are necessarily superior to another one. The choice of the most appropriate metric depends on the specific process that is being targeted. Let's go through each of these types of metrics one by one. Structural measures refer to how is care delivered. Process measures refer to what is actually being done at the point of care. Outcome measures refer to what ultimately happens to the patient. So in this example, the rates of healthcare-associated infections. Now that you've understood the problem, identified the areas for change, and decided on how to measure your progress, it's very important to state your goals explicitly. Project objectives are usually formulated in a SMART format, which stands for specific, measurable, achievable, relevant, and time-bound. And this is also the second common pitfall encountered when planning a QI project: failure to use an appropriate SMART objective when planning your project. An example SMART objective for improving hand hygiene might look something like this. Breaking this down according to the SMART criteria, you can see that this objective is both specific and achievable in that it defines exactly what is the desired target improvement. It is measurable, since we have defined exactly how appropriate hand hygiene will be measured. It's relevant because it defines the population that is being targeted. And it is time-bound in that it gives a specific time frame during which we hope the improvement will occur. All of these steps are interrelated in that determining the right improvement strategy is dependent upon having taken the time to understand the problem, identify the areas that need to change, and decide on an appropriate measurement strategy. The goal of creating effective and reliable improvements is to ensure behavior change on the part of the participants in the project in order to create what is termed standard work. There are, broadly speaking, 3 types of improvement strategies: predisposing, enabling, and reinforcing. Predisposing interventions can almost be thought of as prerequisites. These communicate the knowledge that staff need to understand in order to facilitate the desired behavior change. Of course, in a training environment like UCSF, educational interventions are very important. However, it's critical to understand that educational interventions on their own usually only produce small-scale behavior changes that usually are not particularly durable. Another common pitfall in quality improvement work is relying solely on educational interventions to achieve a specific type of behavior change. A combination of predisposing, enabling, and reinforcing interventions is really necessary in order to produce lasting behavior change. Enabling interventions facilitate making the desired behavior natural. In the previous module, we discussed the concepts of the lean operating system and its emphasis on reducing waste. What this often means in a specific environment is reducing unnecessary steps and making work as efficient as possible. These types of interventions facilitate performing the right thing every time. Reinforcing interventions facilitate performing standard work by reinforcing and rewarding the right behavior. Data auditing and feedback is a very powerful reinforcing intervention, both in order to highlight successes and to draw attention to areas which may need more assistance. One other common pitfall, though, is important in remembering when dealing with information technology enhancements. In our current era, much of what we do is dependent on using the electronic medical record appropriately. And it is very tempting to think about introducing reminders or warnings within the electronic medical record as a way of reinforcing behavior change. However, a large body of research now demonstrates that a proliferation of warnings within electronic medical records can contribute to alert fatigue, which means that busy frontline workers will ignore any of the well-intentioned alerts. It's often tempting to roll out a large program at once involving several different interventions, but a better approach is to choose one intervention at a time and implement it using the principles of the PDSA cycle: plan, do, study, and act. When doing so, implement one intervention at a time, even with just a few patients, and see how it works. If it works well, expand it to a larger population of patients, and then think about adding another intervention. If it doesn't work, it's better to learn that earlier rather than forge ahead with an intervention that isn't working. In the case of hand hygiene, the predisposing interventions included an educational campaign. The enabling interventions included the ergonomic interventions and also included the critical role of medical center leadership in prioritizing hand hygiene as an issue and committing resources to the problem. The reinforcing interventions, which involved more upfront effort but were also higher impact, included measuring and feeding back data stratified by each unit and each service, and personal feedback by trained observers on each ward who would observe hand hygiene and provide feedback when they saw that hand hygiene was not being performed appropriately. Now that you've understood the problem, figured out a measurement strategy, set goals, and created improvements, we can move on to building upon successes and sustaining change. Sustaining behavior change involves creating standard work. We study the best way to do something so that we can document it and disseminate it so that others can benefit from that best practice. It's important to understand that standard work is derived from evidence and data and is always formulated with the direct input and engagement of frontline workers. The development of standardized work should be viewed as a success. What it means is that you have identified a problem and successfully figured out the best way to address it, and now you're ready to disseminate it. This is also, unfortunately, sometimes the source of a common pitfall in QI. When standard work is disseminated in a top-down fashion, and the evidence behind it is not explained, or frontline workers are not engaged in the development of standardized work, then this may result in a situation where it's difficult to obtain buy-in from those on the front lines. Several interventions were crucial in sustaining the process of improving hand hygiene. By making sure that the desired behavior was introduced, and then ergonomic changes were put into place to make sure that hand hygiene dispensers were readily available, the process of performing hand hygiene simply has become muscle memory. The accessibility of data so that clinicians could see how they were performing on a unit-by-unit basis and a service-by-service basis helped identify successes and target areas for improvement. And the engagement of senior leadership prioritized hand hygiene as an important organizational objective and helped celebrate successes as hand hygiene rates improved. As a result of this process, our hand hygiene rates at UCSF are now consistently over 90% on all inpatient units. Along with this, we have seen a decrease in our rates of several types of healthcare-associated infections. Through this module, hopefully you have learned the 6 key steps of a quality improvement project, as well as the 5 common pitfalls that can be encountered when engaging in quality improvement work. Our hope is that by using the concepts in this module and the concepts of continuous process improvement in general, we can transform UCSF Health into a learning organization, one that truly uses the principles of continuous process improvement to close the implementation gap and make sure that the patient care that we deliver matches our scientific understanding of disease. We also hope you recognize that this process is something that all of us can and should engage in. But if you need help, the CPI Hub is here to help you. This concludes CPI 101 Module 2, Quality Improvement. Thank you very much for your attention.